Good afternoon. My name is Dr. Julie Steck, and I'm a psychologist with CRG Children's Resource Group, and I want to welcome you to today's webinar, which is entitled Mood Disorders 101, Recognizing and Intervening with Children with DMDD. So I'm going to take my picture off now so you can concentrate on the content, but a couple of notes. First of all, there is a handout from this presentation that you can download. It will be a PDF copy of the PowerPoint. You can ask questions during the webinar, and I will try to answer them at the end of the session. And we will be having polls throughout the webinar. So I hope to make this a little bit interactive and provide some concrete information for those of you who work with children either as parents, relatives, educators, or other mental health providers. So with that, I'm going to go ahead and get started. Oopsie, guess not. Here we go. So our objectives for today are that participants will develop an understanding of DMDD. They will be able to identify 3 triggers for temper outbursts in the identified child, that they will develop 3 new strategies for identifying with the identified child, and participants will identify 3 coping mechanisms for the family or the classroom. So I'd like to find out a little bit about who's in the audience today. So I'm going to launch our first poll. So if you will all respond, what role you're attending. I have to enable that poll, so okay. So I'm going to close the poll now, and what we see is that about 58% of you all are attending as parents, 25% as teacher educator, and 25% as mental health professionals. So it's good to know that we have a mix in the crowd, and I think the seminar will make sense to you if you try to keep one child in mind or 1 or 2 that you either know or work with. Okay, not sure why my PowerPoint's not moving forward. Okay, so DMDD is a new addition to DSM-5, which is the Diagnostic and Statistical Manual that those of us in healthcare and mental health use for diagnosing individuals. This was published in 2013. The DMDD was added to the manual to address concerns regarding the overdiagnosis and treatment of children who were considered bipolar disorder. So through the early 2000s, an increasing number of children were being diagnosed with bipolar disorder because we really didn't have a better diagnostic label. And research was telling us that most of these children did not grow up to have bipolar disorder, but typically they grew up and as adults had more symptoms of depression and or anxiety. So the new diagnostic label was added to address these concerns. The diagnostic criteria is lengthy, and I don't want to spend too much time on this, but do want to review it. Those with DMDD have severe recurrent temper outbursts manifested verbally and or behaviorally that are out of proportion in intensity and duration to the situation or provocation. And the temper outbursts are inconsistent with developmental levels. So while a tantrum, a prolonged tantrum might not be unusual for a 3-year-old, they are it's not appropriate for a school-age child to be having prolonged tantrums. And the outbursts occur on average 3 or more times a week. And some of you might be thinking, I wish we only had 3 a week. But this is to say that that number of tantrums is not typical for children from ages 6 to 18, which is the age range for DMDD. The mood between temper outbursts is persistently irritable or angry most of the day, nearly every day, and observable by others. The criteria have been present for 12 or more months, and there's not a period between those symptoms when these behaviors or symptoms diminish. And the behaviors are present in at least 2 settings and severe in at least 1. Typically, a child with DMDD starts to exhibit the behaviors at home, and then those slowly start to show up in other settings such as daycare, with grandparents, and oftentimes school is the last place they show up. The diagnosis should not be made prior to age 6, although I think there are many children with DMDD that we have suspicions about prior to age 6. And these criteria need to be present by age 10. And they do not occur primarily during a major depressive episode and are not better explained by another mental disorder. So we have to make sure that the symptoms are not due to physiologic effects of a substance, such as we know that children, when they're put on steroids, can have increased anger and mood lability, so that would be a reason to exclude it, or primarily due to another neurologic condition, although later I'll talk about comorbidities with neurologic conditions. We cannot diagnose DMDD with oppositional defiant disorder, intermittent explosive disorder, or bipolar disorder. So it doesn't mean that the child might not have had a diagnosis of one of these, but if we are diagnosing DMDD, we have to exclude those other diagnoses and no longer list them as diagnoses. We do not use this diagnosis if the child has ever had manic or hypomanic episodes of more than 1 day. So in doing our diagnostic evaluation, we have to make sure that the child does not have mania or hypomania for prolonged periods, because that would say that we should be looking more at a bipolar disorder. So just some general facts about DMDD. It's more common in males and school-age children, so we tend to see less of it as the child enters adolescence. That doesn't mean they aren't experiencing anxiety and depression, but we may not be seeing the temper outbursts, and it is more common in males. The prevalence in the population is probably about 2 to 5%. There are high rates of comorbidity in those with DMDD. ADHD, disruptive behaviors, anxiety, learning difficulties, tics. Families say they walk on eggshells. So as I sit in my office and I see families with concerns about their children, these families don't know each other, they haven't talked to each other, but they are saying we all walk on eggshells. And they say that their children don't have tantrums, they have rages. So the children will disrupt the family functioning, and when they become upset, it isn't just a minor tantrum or pouting, it's a rage. So as I said earlier, the term in DSM-5, the term bipolar disorder is used only when there are distinct periods of mania or hypomania, in addition to episodes of irritability and depression. However, in we now would refer to most of these children with DMDD, but much of what was written prior to 2013 would be found in books about the bipolar child or childhood onset bipolar disorder. The primary symptom of DMDD is mood dysregulation and irritability. So I use this symbol to show that while most individuals have an even keel like this, individuals with DMDD don't come up above this very often, but often are going below the curve. Secondary symptoms of DMDD involve cognitive dysregulation. So individuals with DMDD have poorly regulated working memory, visual spatial reasoning, planning and organization, and attention, and their mood dysregulation in school is usually manifested in math and written expression. They may have a coexisting reading disorder, but we tend to see the mood dysregulation interfere most with math and written expression. We also know that DMDD causes family dysregulation. It can cause marital conflict. It takes a long time, often, for parents to get on the same page about how to manage their child with DMDD. It can cause financial strain. Families with children with DMDD tend to spend a lot of time pursuing evaluations and treatment. They often get called to pick their child up from a daycare setting, so they miss work, or they have to stay home from work because a child's been suspended. So there tends to be a lot of financial strain in families with children with DMDD. It causes difficulty with parents' work schedules due to the common difficulties with attending and remaining in daycare and school. It has a very significant impact on siblings. Families with children with DMDD often feel isolated from friends and extended family because it can be difficult to take their child to family events. They're reticent to take them to public settings, do things like go out to dinner, go to parties with other families. For some individuals, having a child with DMDD can bring up shame and fear through reliving old memories, either of their own behaviors or their siblings' behaviors if they have a sibling that manifested these same difficulties. And it often causes anger towards others. Anger towards others because those others aren't having the same difficulties and may want to offer advice, but they feel that they aren't understood by those offering advice. Children with DMDD do not suffer in silence. These children, when they're upset, everyone knows it. They have a very low tolerance for frustration. They tend to have poor working memory and slow speed of processing, and they see the glass as half empty. So let me launch another poll here. So please indicate which the individuals that you know with DMDD experience. Okay, well, it looks like 100% say impulsive behaviors and emotions, obsessive interests, and social anxiety coming in second, irrational fears and separation anxiety. And I would say that's very, very much what I see in clinical practice, that the the children we work with have multiple issues which impact them, including multiple forms of anxiety. So children with DMDD have trouble putting the needs of others before their own needs. Let me talk about that for a minute, because I often see children who have been diagnosed with autism spectrum disorder because they're described as self-centered, having trouble showing empathy, trouble being caring about others. And yet we know that children with DMDD, when their mood is not stable and things are not going their way, have a very difficult time putting the needs of others before their own needs. So they may have an autism spectrum disorder, but oftentimes it's really their mood regulation disorder that causes them to have difficulties with interaction with others. Those with DMDD perceive comments and reaction of others negatively. There have been multiple studies that look at the perceptions of children with DMDD, and what they find is that their perceptions are chronically negative. So they rarely think that someone is saying something nice to them, even when they are. They perceive it's not fair, so they may be getting an exactly equal size of birthday cake to their sibling, but they perceive that they're getting less and it's not fair. They perceive neutral facial expressions as negative. So I think it's important to realize that a child with DMDD may not be perceiving the situation the way others do, and that they're reacting according to their perception. I think I said previously they have low tolerance for frustration, and they often gravitate to the dark and negative. So even though they may have fears that keep them from sleeping alone at night, they tend to like scary, dark types of movies or video games. So we're going to talk a little bit about common comorbid conditions, because when we're treating DMDD, we have to be considering all of the comorbid conditions to know how to best intervene and adjust the environment. So I would say that virtually all of the children that I see with DMDD have comorbid anxiety, and many of you endorsed numerous anxieties as parts of the DMDD. At a young age, they will often have separation anxiety, usually from the mother, and even though they have separation anxiety from the mother, they will also show the most aggression towards the mother, because the mother is the one that helps them through difficult times, and also the one, so they don't want to separate, but also the one who has to tell them no. Depression, and even if these children don't have full-blown depression, they have kind of a chronic negative mood or dysthymic condition, and they can lapse into periods of depression when they are more irritable and angry. ADHD, we'll talk a little bit more about the ADHD in another slide, but almost always we're going to see a coexisting ADHD with this population. Specific learning disorders such as dyslexia or reading disorders, a nonverbal learning disorder, which can cause a math disorder, disorders of written expression. And so what we see is that in school settings, as the work starts to become more difficult for them, the school will see more of the behavioral outbursts, because the child's capacity to deal with the frustration when things are hard is limited. We can see DMDD in individuals with autism spectrum disorder. So while the autism spectrum disorder remains the primary condition, the DMDD will often exacerbate the interventions and the educational strategies that we typically use for those with autism spectrum disorder. And we see a higher occurrence of DMDD in individuals with known neurological conditions, such as cerebral palsy or seizure disorders. So while we need to identify the neurologic condition, we can also diagnose DMDD as a comorbid condition with the neurological condition like cerebral palsy. So let me talk about the ADHD component that goes along with DMDD. And I'm spending more time talking about the ADHD component because I think that understanding the deficits in executive functioning that go along with ADHD can help us know how to help the child. And oftentimes when we can treat the ADHD both through medication and behavioral interventions and helping the parent learn how to adjust the environment for the ADHD, we can see a lot of the behavioral difficulties improve. So children with ADHD, whether or not you have DMDD, have poor impulse control. They have excessive activity for the context. So they talk too much, or they eat too much, or they move too much. So people always think of it as physical hyperactivity, but it can be other forms of excessive activity. Children with ADHD have a short attention span for activities not of their choice, but a long attention span for things they choose, such as video games or watching videos on Netflix or playing Legos. Children with ADHD have difficulty with multitasking. So if they're doing one thing, they have trouble listening, they have trouble listening and doing at the same time, they have trouble going from one task to another. They're more distractible, and they have poor time concept. So that poor time concept plays in when they're doing something they enjoy, they never have enough time. When they're doing something that they don't enjoy, it always seems to last too long. So let's talk about treating ADHD, but first I want to launch a poll here. So let's launch this one. So this question is, the child or adolescent I know is on medication and it has been helpful. Okay, we're going to close the poll in just a couple of seconds here. I think about 75% of you have voted. So, okay. So I asked this question because I think many times, very often, medication can be very helpful, but it's certainly not the only form of intervention we should be using with children, probably with any condition, but particularly DMDD. So where do we start in addressing and treating DMDD? Well, I think the first thing we have to start with is appropriate diagnosis of the disorder and also coexisting disorders. So we need to know not only does this child have DMDD, but what are the other coexisting or comorbid conditions that go with it? Once we know that we have DMDD, I think the next most important step is parent and caregiver or teacher education regarding the issues addressing the student. I can't emphasize enough how important educating the parents and others involved with the child about DMDD, why the behaviors occur, what we can do prior to a behavior occurring to keep them from occurring. Some of you may know that, and I will refer to Dr. Ross Green later in this talk, but Dr. Ross Green has written a number of books. The first was The Explosive Child, which was a wonderful book, groundbreaking, helping us think differently about how to intervene with children with behavioral difficulties. And he's in Westfield doing a conference today, and I was there this morning. And he talked a lot about changing the mindset of parents and teachers to realize that children will do well if they can, and we need to set things up so they can be more successful. We then need to build positive parenting and teacher support. And this only happens through good communication. I find that when children are having behavioral difficulties and we don't have an explanation, there's a lot of finger pointing between home and school, and we really need to come to the table together and start to talk about the needs of the child and what we can do to help build a positive environment. So the fourth part of intervention is consideration of medication. And I think that consideration of medication is an important aspect of treatment, although I want you to know, again, it's not the only aspect. And the consideration of medication is kind of an ongoing dialogue with the family, with the treating physician, and with who's ever working with the family. The next part is building in individual and family therapy, and that means working with the family with a focus on the individual. So someone asked me earlier today how I do therapy with young children, and I said, well, really it's mostly parent coaching with some time with the child. And the older the child gets, the better they are to articulate their needs, and we can spend more time with them. But when I say individual and family therapy, really almost all of the sessions include both the child and the parents. The next part of treatment is providing appropriate services and supports in school programming when the emotions start to impact learning and functioning in school. And as I said later, oftentimes the child will do relatively well at school until the demands of school outstrip their capacity to be successful. So they want to do well, and when they start to struggle, it comes out emotionally. And then, as I said, we have to recognize and treat, the last component is recognizing and treating anxiety, depression, and or ADHD in the parents. And oftentimes in working with families, one or both parents start to identify some of their own symptoms that make it difficult for them to provide what their child needs. And when they're open enough to say that, we can then start to help them so they can better help their child. Okay, so the next poll is going to ask you to identify the most common trigger for the child you know. So let's see what the most common triggers are. So go ahead and put your vote up there. So we'll wait about 5 more seconds and close this poll down and see what we have. Okay. So we have 71% of the votes counted. We'll go ahead and close the poll. So what we see is that 80% of you said that transitions from something they enjoy to something they don't enjoy is the number one trigger. The word no, number two, and homework and expectations that they complete a non-preferred activity. And those could be the same thing sometimes. So I would say that you all are seeing the same things in the children you know that I hear about in my office. So I apologize, my computer is not wanting to, there we go. So the word no is probably what most parents say to me when I say, what's the most common trigger for your child? They tell me it's when they have to stop something they're enjoying. And so we talk about don't give them what they enjoy till they do what they need to do. Leaving home to go somewhere they don't want to go. Homework, putting on clothes they don't like, don't feel good in, and being served food they don't like. Those are all the kind of common triggers that I hear in my office. So I want to talk a minute about the basket method. So we're going to start to talk about things that might be able to help. And the basket method is introduced by Dr. Ross Greene in his first book, The Explosive Child. And I'm simplifying it here. But what I like to talk to parents about is that they can actually get 3 baskets, or they just can have a mental basket, but somehow having 3 baskets out on their counter can help them remember to do this. Basket A are the have-tos. These are the things that children have to do. These are things like we have to be toilet trained, we have to eat meals, we have to go to school. The second basket are the parents' set of want-tos. What do we want to have our child do? Well, we'd like them to make their bed, but it's not a have-to, it's a want-to. We'd like them to brush their teeth 3 times a day, but we could settle for 1 or 2. We want them to clean up their room every night, but we could probably settle for doing it on Saturday with assistance. And basket C's are the let go of it. These are the things that you know are always going to cause a huge explosive outburst, and they probably aren't really that important in the scheme of things. So what I like to think about is parents need to decide together what are the have-tos, what are the want-tos, and what can we let go of. Now, and the same thing goes in a school setting. Now let me pose this question for you all to respond to. How many of you worry that your other child or other students will feel it's unfair if you don't have the same expectations for them as you do for your other child, for the child with DMDD that you do for the other children? So we're going to close the voting here in a minute. It looks like about 67% of you say yes, you worry about it, and about 33% say no. And I would say that most parents and teachers do worry that it's not fair to the other children, and I totally understand that. But I think that in reality, the other students or other children in your family don't want to be the child that has the outbursts all the time. So if you have a mentality of we as parents or I as a teacher do what is best for each child, and you show that in your actions, then I think children will understand that. So the basket approach is just one approach that I think can be very helpful in terms of helping families have a mindset of we eventually we may be able to move things from basket B to basket A, but when we start trying to lessen tantrums and rages, we need to start with basket A behaviors. And as one parent said to me one time, I learned that if I put things in basket C, that giving in does not mean giving up. And I thought that was a great phrase to remember. So what are some other strategies? For this group of children and adolescents, it's so important to have a consistent and predictable schedule and to make that schedule visible to the child. Many times when I'm working with families with a child with DMDD, there's been a divorce and the parents, the child is going from one family to the other, and the child will tantrum, and sometimes it's simply because they don't know what the schedule is. The parents know what the schedule is, and the parents know 2 days here, 2 days there, then every other weekend, but that's very hard for the child to keep straight in their mind. So if we can make a visible schedule for the child to see, if we can make a visible schedule of what they need to get done in the morning, then it tends to prevent less talking and reminding and criticizing and helps to reference the child back to the schedule. We also need to note changes on the schedule because schedules change, and children with DMDD are not very flexible in adjusting to those changes. So we need to let them know in advance, note it on the schedule, and make adjustments for our expectations at those times. I encourage parents not to say things like maybe or we'll see, because in the child's mind, that often translates to yes or you promised. So what I would encourage you to, I don't think you should say no too quickly, but also don't promise to tell them later, because that will cause, you may defer a tantrum now, but have it later when you don't follow through with what they perceived you would. I strongly encourage families to minimize the transitions to and from home. You know, we all have busy lives now, and children are in many, many activities. And children with DMDD, one, don't typically like to go lots of places, especially if it's not for them. So I think it's important for parents to try to organize their schedules so they don't get the child home, let them get engaged in something they enjoy, only to tell them it's time to go again. So if you're going to have to run errands or take a child to a music lesson, try to prep the child with DMDD that you need to do that, and then let them know when they get home what they will be able to do that they enjoy. Try to find a way to take the home out of homework. And this is something that a 6th or 7th grade child said to me one time, I wouldn't mind homework if they could take the home out of it. I think if there's any way you can have the child stay at school to get the homework done, as they get into middle school and high school, make sure they have a study hall, maybe have a tutor that works with them 2 or 3 days a week to get homework done. Anything to keep the homework from all being done at home can help with meltdowns. Negotiate when feasible. If you negotiate with your child, and Ross Green has a lot of information and strategies on this, and they're listed in the references at the end of this webinar, negotiating does not mean you're giving in. It means you're trying to find, how can I make a difficult situation acceptable to this person who's not very flexible. But once you negotiate, you need to stand by your agreement. So the fastest way to lose the trust of your child, whether you're a parent or a teacher, is not to stand by your agreements. So if you negotiate to find a solution, make sure you keep up your end of the bargain. So what we know from the research is that individuals with ADHD, and just ADHD, so not even DMDD or other conditions, have at least a 30% delay in behavioral, self-regulation, and emotions. Unfortunately, we live in a world where people around us keep ratcheting up expectations. So, for example, what we require of fifth graders in school in 2016 is more like what we required of a seventh grader in 1990. Unfortunately, the frontal lobes of the brain haven't gotten bigger in that time. So children with ADHD were not able to do what children could in 1990. They sure can't do what we expect in 2016. So even though teachers or administrators tell you that your child should be able to do such and such, in your mind you have to say, but this child is 30% delayed over the expectations, below the expectations of other children their age. So things we do need to do. We do need to remain calm when a child with DMDD gets upset, and we need to help the child think. No one performs at their best when there's too much emotion. And what happens when people are upset or there's too much emotion is their ability to think is compromised. So as an adult, we need to help the child think. But that doesn't mean we have to be talking a lot. We may need to just stay calm until they are able to think. Don't invade the child's space when they're upset. So reaching towards the child, even if you're trying to do that out of love, will be perceived as you're going to grab me. So especially in school settings, I really encourage people not to invade the child's space unless absolutely necessary. We need to talk less. And I say that to parents frequently, and I'm sure as a parent I didn't always do that. But children don't need more talking to. We need to listen more and talk less. And we need to allow the child to retreat to a predetermined safe space to calm before we discuss the topic further. Don't raise your voice. Don't reach and approach the child in an intimidating manner. Don't overreact. Don't talk too much. Don't make threats. And don't try to win the battle but lose the war. So Dr. Rowland, who's a psychiatrist in our office, would always say there's only room for one hand on the panic button. So I purchased some panic buttons, which I keep in my office, and you'll see this young man with his hand on the panic button. And let me show you what that sounds like. So when a child's panicking, a parent should not be reaching for that panic button too, because then we have two people panicking. So remember, there's only room for one hand on the panic button. So a couple of words for wisdom. Children do well if they can. I think parents do well if they can, and I think teachers do well if they can. I think we all try to do the best we can at all times. And when a child isn't doing well, it's our responsibility to try to understand what we can do to help adjust the situation so that they can do well. the perfect parent is the best parent for the child they have. I think one of the things we see is when parents have their first child or their second or their third, they are always trying to be what someone else has described as the perfect parent. And unfortunately, our children don't come with handbooks. Oftentimes, the first child, or maybe not the first child, but one child will automatically do what they're supposed to do, and parents think they're wonderful parents. And then they have a wake-up call when they have the child that isn't so easy. So the perfect parent is the best parent for the child they have. And giving in does not mean giving up. Okay, a couple other quick polls, and then we'll go to questions if there are any. Okay, so as a parent or a teacher, have you learned to adjust your expectations? Or are you still in the process? Okay, we'll give it another few seconds. Okay, 69% of you say yes, you've learned to adjust your expectations. And that's great. I think if we are rigid in our expectations, then rigid versus rigid does not work well. And as usual, when I give presentations, I'm usually singing to the choir. And the last one is, are you able to keep your hand off the panic button? Okay. And I think most of you are working hard and doing a good job at that. What I would say, if as a teacher or as a parent, if that is hard for you, I would step back and ask yourself, is there something about you that is getting in the way? And that doesn't mean you shouldn't be the child's parent or teacher, but what are some things you can do to help? So I have tried to list a few of the readings and references that I recommend. Again, Ross Greene, I think you see over and over again on my list. I would strongly encourage you to become familiar with his work, and even if you don't read every word of his books, to understand what he has to say. So let's see if we have any questions here. Let's see. There are a couple. Okay, is there a support group for parents of children with DMDD in Indy? And I'm going to have to say that I don't know of any. I have parents ask me that a lot. If anyone in the audience does know of one and you want to submit a response on chat, we can see what you have to say on that. Let me see if anyone. I don't see any on that. So, you know, I will tell you this, if we ever hear of one, we will post it on the Children's Resource Group website. So you might check back there periodically. Okay. Any recommendations on how to communicate this information to my child's school, or how the school can communicate this to a parent? Oh, that's excellent. Well, first of all, I want to say I was very excited this morning. As I told you, I was at a Ross Greene conference this morning up in Westfield at Westfield High School, and there were 400 people there, parents, some parents, but largely educators. Now, the schools may not always use the term DMDD, but I think they're starting to understand that many times the behaviors are a result of what Ross Green refers to as lagging skills. So one thing I would say to you is that this webinar will be posted on our CRG website next week, and it'll be up there so anyone can view it if this has been helpful. I think finding a time to sit down and talk one-on-one with the well, I won't say one-on-one. I encourage parents to always have another person in a conference with the teacher if there's a chance that it could be difficult. So whether it's the school counselor or the principal, I would encourage you, but I would sit down and talk about and be open about the concerns you have, and use lots of I messages rather than telling you, the school or the teacher, what you're doing wrong. Say, these are the things I've tried, these are the things I see. I don't know how you might do that at school, but I thought we could talk about that. So someone says, can we start a parent support group at CRG? And I think we can certainly try that. We've had some in the past, and we can try to get one together in the future. And the key will be getting a consistent group of people coming. So we'll certainly, and again, if we start one, we'll put that up on our website. What is the possibility or statistics for DMDD, kids with DMDD, to end up with a bipolar diagnosis? Well, good question. So bipolar disorder in the general population, this as adults, estimates range from 2 to 5%. Probably the broader definition of bipolar, meaning people who definitely have mood swings, but maybe not, but not prolonged manic periods and not needing hospitalization. That statistic is about 5%. Those with severe mental illness with bipolar is probably more in the 2 to 3% range. So we don't think there's a one-to-one correspondence between those with DMDD growing up and having bipolar disorder. But I think there will be a percentage, and I'll use an estimate of probably, a small percentage of those with DMDD will have bipolar disorder. Bipolar disorder is very strongly correlated with family history of bipolar disorder. So we know there's a greater likelihood if first-degree relative or second-degree relative has bipolar disorder. I think one of the things that's always hard in the differential diagnosis of bipolar disorder, or knowing who's at risk, is in children who have been adopted. So there is a chance that children with DMDD may have bipolar disorder. There's a much greater chance that they will have depression and anxiety. Well, I certainly want to thank you all for being here today. I do want to let you know about our other upcoming webinars, if I can get them to come up. So on Wednesday, December 7th at noon, Dr. David Parker and Dr. Dana Lassick in our office will be doing a webinar on the emotional health of college students, challenges and supports. I think we're becoming increasingly aware of the emotional challenges of college students, as are colleges and universities. So this webinar will really focus on those challenges. And then on Friday, December 9th at noon, I will be presenting on ADHD, more than an attention problem. And in that, we will focus on some of the deficits in executive functioning and impulse control that go along with ADHD, and strategies that can be used to help. I do want to thank all of you for being here with us virtually today. If you have recommendations for other topics you'd like to see, let's see, you could let us know. I do have one more question that popped up. Is it possible to print the PowerPoint from the webinar once it's on the CRG site? That I don't know, but I think we could certainly post it, not with the webinar, but somewhere else. So Jessica Rumpel, who's a wonderful administrator in our office, is monitoring this webinar, and I'm sure she has heard that request and will be on it ASAP. So we'll try to get the PowerPoints available for printing. I want to thank all of you for joining us today. It's a beautiful day out there, and I know you took time to be here. I hope you gained something from it, and most of all, remember, children do well if they can, parents do well if they can, and teachers do well if they can. Thank you for joining us, and have a good day.